This is Talk Business and Politics with Roby Brock.
And welcome to the program. I'm Roby Brock. Thank you so much for joining us. Well, if you haven't been paying attention to some of our coverage lately, we have been covering a potential hospital financing crisis in Arkansas. We have seen the pandemic funding is starting to dwindle. Inflation costs have driven up the cost of supplies. And there has been a worldwide labor shortage in staffing, particularly in the nursing area. And that is where we begin our interview with Cindy Gillespie. She's the Secretary of the Arkansas Department of Human Services. Always a pleasure to have you with us, Madam Secretary. Thanks for being here.
Thank you, Roby. It's always a delight to come talk with you.
All right. Frame this debate for me as you understand it. What is the status of financing for many of Arkansas's hospitals, and what do you see at the root of some of this funding problem?
Sure, I'll be happy to. As we've all gone through the last 2.5 years since March of 2020, when the COVID pandemic began, one of the things that has happened with hospitals in our state is that their normal sources of revenue really went down. I know from here, when we watch Medicaid, what we started to see is hospitals were dealing with having to change beds over so that they use them only for COVID, right? They began to have staffing shortages and issues and had to reduce the number of beds. A lot of their revenue often comes from outpatient. And if you'll remember, we pretty much cut off doing, all over the country, everybody cut off doing outpatient. Folks did not go unless it really was an emergency. So you didn't do outpatient surgeries, you didn't do outpatient visits. And the hospital's revenue dropped enormously as they went through this period. So while they were really battling on the front lines to keep people alive and well, their normal sources of revenue were declining. At the same time, their expenses were rising. And I think I saw recently some national statistics. The cost of labor over this last 2 years inside our hospitals has increased about 20%. The cost of supplies has increased also about 20%, and the cost of drugs has increased about 20%. So when you see, it's been for many of them, it's just been a perfect storm, right? Revenues going down, expenses going up. And what we are all looking at right now is the issue, and we've been working with a number of hospitals here over on the Medicaid side, when they need some help by being able to get an advanced supplemental payment. We work with them on that. We do things to help where we can. And most hospitals, while this has been very rough for them, are able to figure out a plan to get back to sustainability. We have seen revenues to go back up now. We have seen people are going back to the doctor, people are going back into the hospital. People are getting all that outpatient surgery caught up and all the outpatient visits. And so revenues are back up and are starting to rise. Yeah. But there was a long period where they didn't get their revenues. So if you were not robust enough going into this, it really, really depleted. And so what we're doing right now is trying to anticipate being able to have a way to help hospitals who may find themselves now in jeopardy.
You have talked me out of wanting a second career as a hospital executive, so just know that you've accomplished your goal on that.
Good.
You mentioned the advanced supplemental Medicaid payments that the state is participating in. Are there other things that the state can do? What else do you see as potential solutions on the horizon, whether it requires policy changes or legal changes, or what are some things that are being discussed?
I'll mention a couple of things. Right now we are undergoing rate reviews on the Medicaid side, and I know the hospitals are doing the same with the private insurers and with other payer sources that they have, to be able to look and see, all right, with the changed labor costs, with the changed supply costs, do the Medicaid rates themselves for hospital services need to change? So we've got that underway, and that should be done by the end of this year. And so that should help recognize the changed environment. But more particularly this past week, one of the things we did, well, actually last week, one of the things we did was went to the ARPA steering committee. and asked if we could get $60 million put into a fund that DHS could have to be able to provide some short-term support to a hospital that came to us that was in immediate jeopardy of having to close their doors. That request for the funding was approved by the steering committee. It will go before the legislature next week. And then if approved, we will put out an application by mid-month, so that if a hospital finds themselves in that state, what we would be able to do is provide basically up to 3 months of payroll for them, which would give them an infusion of cash that could help them have the time to put together a sustainability plan.
I'm not going to sneeze at $60 million because that's a lot of money, but I've talked to some of the hospital executives and they've communicated what some of their losses are to me. And I don't think $60 million is going to go very far in addressing that crisis. Is there some longer term funding reforms that you think could happen that might help replace some of that revenue or supplement some of that revenue?
The $60 million is really aimed at if you look at what we've asked for the $60 million with the idea that we want to have this available in case what we're hearing from now are some independent hospitals. They're not part of the large systems. They are standalone independent hospitals. They're not critical access hospitals who get special Medicare payments. They're usually small or mid-sized hospitals, and they therefore have less in terms of assets or other resources to go to. And so this 60 million is really sized to that, to the idea that if one of those hospitals is coming in and having those issues, we would be able to help them. And their payroll labor costs usually run them anywhere from about $1.5 million to $2 million a month. So 3 months would be about $6 million for a hospital of that size. And that's where this is aimed, with the idea that then if we have the funds remaining, we would then move to the critical access hospitals, which are really the small hospitals. Most of these hospitals we're talking about, Roby, are rural. Yeah. And so that's where you have less assets. For the larger systems, I think one of the things I just said very honestly to the ARPA steering committee is that if one of our large systems gets to the point where they are actually in immediate jeopardy of closing, which would be quite significant, not just for Arkansas, right, but quite significant for them because they have a lot of assets and they often have a lot of efforts underway that they can slow or do. Then we would have to, as a state, actually look well beyond, as you just said, the ARPA money. We'd actually have to be, as a state legislature, the executive branch, and probably industry coming together with them to figure out what are we going to do about that, because that would be a very, very significant issue and it would be costly.
Let's shift gears and talk about a longstanding problem that was addressed earlier this past week. Legislators approved, or I guess endorsed, a plan to provide services for more than 3,200 people that are described as intellectually or developmentally disabled.
Yes.
Before we talk about that solution, tell me a little bit about who that population is.
Sure. This population is, these are individuals who, by and large, their disability, their intellectual disability, is something that came at birth, and they developed their disability before they were 18 years old, and therefore they'll meet a standard of developmentally disabled. This population, these individuals need extensive functional help. They can't perform many of the normal activities of daily living by themselves. They have to have someone help and care for them. They require a lot of support. And Arkansas years ago did a waiver, a Medicaid waiver, and that it's called the Community Supports Waiver. And this waiver allows us to provide these services to people in their home rather than these individuals having to go into an institutional setting to live. They can stay with their family, they can stay at home. And then Medicaid then pays providers to come and be in their home and help them with these services. It is, if you talk to anyone who has family members on the waiver, Roby, they will tell you it is a godsend for them. It completely transforms their life to have this assistance. So this waiver has always existed, as it does in all states, with a number of slots that are allowed. And so we are currently at about 5,000 people on the waiver. Over the last few years, we've really been working to find the money and increase the slots. And so we've now gotten it up to about 5,000. But we had a wait list, as you just said, of over 3,000 people who've been on there for years, waiting for a slot to come open. And so one of the things that we did in the last legislative session, extremely excited, was the governor put forward and the legislature accepted the idea of setting aside within the Medicaid budget. They put in an additional little over $32 million with the idea that that state money would be matched by federal money. The federal government, we have a 70-30 match. When we put up 30 cents on a dollar, they put in 70 cents. Mm-hmm. And so the federal money will come in, and we will, over the next 3 years, then be able to take all of the people that were on the wait list as of December off. And so we had to run rules to do that, had to get CMS to approve it, the feds, and then we have to get our legislature to finalize rules, and that happened this week. And so we're all excited to get this underway and be able to get these services to people.
So that funding will allow, I guess, for more staff to be trained or to go in for home health. And I think also it will allow parents or guardians to be able to be properly trained and to be qualified for the same type of payment for being the caregivers of their kids. Am I understanding that that's how the plan will work?
The way the plan works is once you are given a slot on the wait list, then you go into what we here in Arkansas call PASS, which is it's provider-led managed care. And they'll give you a care coordinator who then will work with the family to find the right providers. And the providers, the family and the individual figure out what services they want. They do get to choose the services that fit their need, right? And then the provider, we are essentially, we pay the PASS, and the PASS pays the provider for the provider to go in and provide that support. And the care coordinator at the managed care company, at the PASS, the care coordinator then is working constantly with the family in case there's a need to adjust the services or a need to change them in any way or any issues with the provider. So it's really a team then that starts to work with that family and with that individual.
All right, she's Cindy Gillespie. She is the Secretary of the Department of Human Services for the state of Arkansas. Always great to get her input and insight. Thank you so much for being with us.
Thank you. Appreciate it very much.
We're back with more right after this.